Good morning, everyone. Myself, Dr. Siddhika Dangayach, second year resident from Muzaffarnagar Medical College and Hospital. My topic is assessment of acute pancreatitis using CT severity score and modified CT severity index, association with clinical outcomes and Ranson's criteria. Introduction. Acute pancreatitis is a commonly found condition which presents with a feature of acute abdomen. This is broadly classified into two subtypes. First is the mild edematous type, and the second is the severe or necrotizing type. A majority of patients have self-limiting subtype of interstitial pancreatitis. Only 20% of the patient have the severe subtype, which eventually progress to systemic complication of septic nature. Severe subtype of acute pancreatitis is seen prevalent in 20 to 30% of the patient, which is observed to have multi-organ dysfunction, failure, parenchymal necrosis, and runs an extensive course. Our study was hospital-based observational study. It was done in a department of radio diagnosis at our college. Sample size was 30 and it was done for the duration of 6 months. Inclusion criteria include all the patients who are referred to the department with a clinical diagnosis of acute pancreatitis. Exclusion criteria include patient or the cases with poor imaging study due to poor compliance or motion artifacts, or the follow-up cases of the acute pancreatitis, or the patient with acute and chronic pancreatitis, cases who are below the age of 12 years of age, as Renson's criteria is not done for pediatric patient in our hospital. The patient who are discharged against medical advice or lost to follow-up. It was done under 16 slides CT. Before starting the CT, the patient consent, written or informed, was taken. The correspondent of the CT indices studied with respect to the Ranson's criteria and clinical outcome parameters, which in each case was assessed as the extent of hospital or ICU stay, requisition of the critical care, existence of organ failure, and the death. Suitable statistical significance test was applied for statistical analysis with software SPS 22 with p-value of less than 0.05 will be considered statistically significant. Case 1. Here we can see the patient present to us where we can see that the pancreas appears to be bulky with a mild peripancreatic fat standing and minimal pleural effusion. It was found to have edematous pancreatitis with a modified CT severity score of 4. Second case where we can see the bulky pancreas with peripancreatic fat standing, bilateral pleural effusion. It was found to have the acute pancreatitis modified CT severity index to be 6. The third case where we can find that the pancreas is bulky and we can see the non-enhancing areas of necrosis involving less than 30% of the area with peripancreatic fat standing and minimal bilateral pleural effusion. It was found to have acute necrotizing pancreatitis with a score of 6. Next case where we can see the encapsulated cystic lesion in the epigastric region including pancreas replacing both the body and the tail with internal septation, thick capsular enhancement is noted and surrounding peripancreatic fat standing was seen. It was found to have the intrapancreatic pseudocyst with pancreatitis. Next case where we can see there is the pancreatic parenchyma is replaced by ill-defined peripherally enhancing collection extending to the spleen and extending to the inferior lienorenal ligament and left paracolic gutter. And these were the features suggesting of necrotizing pancreatitis. And we can see the filling defect in the splenic vein, which was found to have a splenic thrombosis. It falls and mild to moderate ascites and the bilateral pleural effusion. It was found to have acute pancreatitis with splenic vein thrombosis with modified CT severity index to be 10. Next case where we can see that in a well-defined hypodense non-enhancing area in the pancreas with adjacent ill-defined fluid collection and extensive peripancreatic fat standing was found to have a necrotic collection. A well-circumscribed in B and C image, we can see a well-circumscribed abdominopelvic fluid collection of homogeneous low intensity with few thin enhancing incomplete septa and abdominal showing air fluid levels. It was found that about 47% of the patients were having the alcohol as a cause for the acute pancreatitis, followed by gallstone, and the third, the idiopathic cause. Out of the three category, mild, moderate, and severe, it was found the most common was the mild, followed by moderate, then the severe. Then the requirement for the hospital stay, it was found that the patient with the A patient with a moderate pancreatitis have more prolonged stay as compared to that of the mild and the severe variety. It was found that the correlation was observed to be better with the modified CT severity index compared to the conventional CT severity index. The R value of 0.35 for P 0.040 for CT severity index, and for the modified CT was 0, R value was 0.53. It was found that the CT severity index with that of mortality, association, it was found that the patient who had severe pancreatitis have the mortality 100%, while the patient with mild pancreatitis have 0% mortality rate. Discussion: CECT is established gold standard for imaging in the assessment of acute pancreatitis. A modified CT severity index to address the various potential limitation of CT severity index. In comparison to the CT severity index, the modified include extra pancreatic complication in the evaluation and helps in simplification of assessment and the degree of pancreatic and peripancreatic parenchymal necrosis. Ranson's criteria has a basis of 11 clinical and lab parameters evaluated in the beginning of 48 hours of hospital, and a score of either more or equal to 3 points towards severe pancreatitis. Our study was conducted between the two radiological imaging systems and the grading of how severe the disease is according to Ranson's criteria, while following up the subjects with regard to the preset clinical outcome parameters and assessing the prognostic value. Overall accuracy of the modified CT was found to have a better than that of the CT severity index for prediction and requirement of critical care, mortality, and development of multiple organ dysfunction. Overall sensitivity and specificity for prediction of mortality by CT severity score was 58.5% and 79.4% with accuracy of 73.8% respectively. Overall sensitivity and specificity for prediction of mortality by modified CT was 91.7% and 64.7% with the accuracy of 87.5% respectively. This study conclusively revealed that the modified CT is more functional in order to screen the patient who have acute pancreatitis of severe grade. A correlation of significance was noted between Ranson's criteria and both CT and modified CT score. The correlation was observed to be better with the modified CT score with R value of 0.53 as compared to the CT score with R value of 0.35. These are my references. Thank you.